I want to thank the organizers for the invitation to give this talk. I'm very excited to be here. So most of what I do falls into what is called digital epidemiology. So epidemiology is a study of the patterns of disease and health in populations and the factors that drive or contribute to those patterns. So this could be social factors, environmental factors, and other types of factors that could possibly contribute to your health outcomes. Digital epidemiology is basically the same thing, but with a focus on digital data. So most of digital epidemiology tends to use data that's not collected specifically for public health purposes. So this could be data from search engines, social media, consumer data, consumer reviews, remote sensing, news, etc. Crowdsourcing data from places like Flu Near You, which is a crowdsourced system. You download an app, you get weekly reminders, and you can submit information about symptoms. So if you had symptoms for the flu in the last week, you can submit that information. I was poisoned, as most of you can imagine. It is about food poisoning. So if you go to a restaurant and you eat something and you get sick, you can go to that website and provide information about your experience. So most of what I do falls into two categories. One, I want to know how we can use the data sources to study health in populations and communities across not just the US, but also in Africa. I also want to know what are the populations that are not captured in this data? So what are the biases in this data, and what is the potential issue if we create technologies that use all these data sources and yet do not account for those individuals that are being represented in this data? What health inequalities do we currently have that we're going to exacerbate? What new health inequalities are we going to create in those communities? So I'm going to talk about the first side of my work, which focuses on how we can use these data sources for public health. And one thing that I'm very interested in, that I just want to mention, is the use of remote sensing data, not just, I think this is very useful globally, especially in African cities. And what we've been doing with this data is trying to understand how you can take an image of a neighborhood and see how health in that particular neighborhood could be different from health in another neighborhood. So for example, if you look at the two neighborhoods in St. Paul, Minnesota, that are 15 minutes away from each other. So you can walk for 15 minutes from one neighborhood to another. But a child born in one neighborhood you expect that child to live up to 65 years, while a child born in a neighborhood, the other neighborhood, expect them to live up to 86 years. So these two neighborhoods are like 15 minutes walk from each other, and I think that's ridiculous. So when you start thinking about what are the factors that contribute to having such a low life expectancy in one neighborhood that's so close to another, you see that there's a lot of issues around access. There are lots of issues around people not being able to find spaces for whether it's healthcare, access to good foods, access to not just grocery stores, but grocery stores that actually have healthy foods. And so this is some of the issues that we're trying to deal with and we're thinking about. But the two topics that I'm going to talk to you about today are completely different, but I hope you find them useful. So the first one is miscarriages. And I did this work with researchers at Boston University, Virginia Commonwealth University, and Khadija is at NYU. So a miscarriage happens when a woman gets pregnant and then loses that pregnancy within the first 20 weeks. There's some interesting things about miscarriages, and Michelle Obama wrote about her personal experience in her book, Becoming. One of them is that most women don't really know about miscarriage until they experience it. It can be very lonely, it can be very painful, it can be demoralizing, and most people usually think that it's your fault that it happened, and just because nobody talks about it, people don't know that it happens all the time. So in fact, 15 to 20% of known pregnancies end in a miscarriage. In the US, that's 750,000 to 1 million miscarriages a year. I mean, just think about it. This is something that happens all the time, and yet we don't talk about it. So when someone experiences it, they tend to think that it's your fault. They think that they're the only one who's ever experienced this. Also, most miscarriages, about 60% of miscarriages is due to genetic problems. So it's not something that you've done, it's not witchcraft, it has nothing to do with you, it's just biology. You get pregnant and you lose that pregnancy. So in 2016, I started thinking about social media and how social media could be useful in addressing the fact that we don't talk about miscarriages. So we got a bunch of data, did some analysis, and then wrote about it in NPR. And that was it. And then 2 years later, we started thinking again about the same problem and got an invitation to write a paper on it. So we collected data from Twitter. We had 291,000 postings in English. There's miscarriages and preterm births. We had data for 2 years, so 2017 and 2018. And then we had about 7,000 personal miscarriage disclosures. We did three sets of analysis. First, topic modeling to identify major topics of discussion. So what are people talking about when they talk about miscarriages? Second, anomaly detection. So are they time points in this data? So if we look to the time series, the time points where we have significant spikes in discussion, and what are the reasons why people are talking about miscarriages at the time points? And then we did sentiment analysis, so we did not use computers for this. This was manual classification. So we had 4 researchers on our team read through these tweets, so the 7,000 personal disclosure tweets, and classify them into different emotions. So we found 8 topics that people were talking about. First is celebrities. About 23% of our tweets were about celebrities, so either talking about celebrities' experiences with miscarriages or responding to a celebrity's disclosure that they had a miscarriage. Politics was another one. This is actually not the best example. There were some examples around, so there was a legislation that was passed in Texas in 2017 that required that fetal tissue from miscarriages, ectopic pregnancies, and preterm births be cremated or buried. And so a lot of women reacted to that because you're already dealing with so much healthcare bill from your miscarriage, and now you have to pay for burial or cremation. Healthcare was another topic that emerged. So people usually talked about insensitive comments from clinicians not fully understanding their experience, and also there were some comments about good experiences, but most of it was about insensitive comments. We had data so the preterm birth emerged as a topic on its own because it's very distinct, and people tended to talk about how to prevent preterm births or the issues around preterm births in the US and what people can do to reduce incidence. Michelle Obama emerged as a topic. So people tended to respond to her disclosure and thought that she was very strong and tried to relate to her people who had similar experiences in the past. Loss and anxiety was another topic, which I'll talk a little bit more about. And these were people, it wasn't just women, but all couples just talking about their experiences and how they felt going through this miscarriage. Flu vaccine was a topic that also emerged from our data, specifically because there was a study that was published linking flu vaccines to miscarriages. And there was a lot of reactions from medical doctors saying, why was this study published, to anti-vaxxers saying, yes, this validates our points, the points we've been making forever about vaccines being unsafe. And a follow-up study was published that actually showed that there was no association between miscarriages and flu vaccines by the same authors. Ectopic pregnancy was also a topic that emerged on its own, and it was very specific, and people tended to talk about it in relation to miscarriages, so people had miscarriage and then had an ectopic pregnancy. In terms of events that were associated with tweet volume, this is from 2017. How many people know what Remy is? Got a few hands, nice. I did not know who Remy Ma was until I did the study. She's a rapper, and she had a miscarriage, and a lot of people were talking about that. There were times when we had some scientific studies that were published, and then people reacted to that. You also had the US Premature Births Report, and people reacting to that and saying that we can do better to reduce premature births in the US. In 2018, we had 2 major events, Michelle Obama's book and a Walgreens incident where someone had a miscarriage and then went to get the medication to complete the miscarriage, and the pharmacist refused to give them that medication. And so there was a lot of reaction to that on Twitter. So as I mentioned, for the sentiment analysis, we manually coded this. We had 4 different coders, and you can see how well they performed relative to each other, or how they compared to each other. Our F1 score for agreement was about 86%. Just to show you examples of what these categories look like, so this would be classified as grief, and we had about 50% of tweets being classified into that category. Anger, I mean, you can tell that person is angry. That was easy to classify. Grief was not always so easy to classify. Annoyance, where people would get angry or annoyed by the fact that there was a lack of understanding between the difference between miscarriages and abortions. So we saw a lot of tweets like that. Isolation was another one we saw, which I think is one major reason why people go to social media in the first place, to find people that they can talk to, people who have had similar experiences, so they can connect with them and get support. Relief was another one. Not a lot of people were relieved about their miscarriage, but we had teenagers who got pregnant and then had a miscarriage, and were relieved that they actually didn't have to go through that pregnancy. And then there was gratitude, where people were either thanking others for sharing their experiences, or you had people being grateful for having friends and family support them. So why do we need to do this? So first of all, we need to normalize the experience of miscarriages. We know it's happening all the time, and it's important that people know that it's happening all the time and that they're not the only ones dealing with it. We want to advocate for mental health screening to be included in medical management of miscarriage. So some of the papers that we read from medical journals did not have this included as part of medical management for miscarriage. And we think it's important, since a lot of people are talking about it, not just on Twitter, but also in survey data that have looked to people who've had similar experiences. And we want to reduce misinformation about miscarriages, so people know that they're not the ones to blame, and that these miscarriages happen to a lot of people. So the second study I'm going to talk to you about is completely different. This one is about food poisoning and unsafe food products. So I started this project while I was at Harvard Medical School, and then I went to University of Washington and continued the same project, and then I moved back to Boston University, and continued working on the same project. So this is one of my favorite projects. All of these people, this is like a combination of people from all the different schools. So it's important for us to have access to safe and nutritious foods. But food can become contaminated at different points of the production process, so from the production to the processing to distribution. So by the time it gets to your table, your food can become contaminated either with bacteria, viruses, toxins, chemicals, and when you consume that food, it can make you sick. So this is what you would expect. Someone eats something, they get sick, they go see a doctor, and then they tweet about it. But this is what usually happens. A lot of people don't go to the doctor. Like, if you've experienced food poisoning in this room, you probably did not go to the doctor. So most people don't go to the doctor. So we have a lot of underreporting of food poisoning or foodborne illness across the US. We don't know how many people are actually getting affected. We have estimates, but those numbers are just estimates. So we turn to social media to see if we can use this data to supplement surveillance data that we have on foodborne illnesses. This is an example of the kind of data we're looking at, where someone said they went out with their family and had food poisoning. We're not just interested in individuals saying that they got food poisoning, we're interested in groups of people. So if you went out with your entire family and you all got sick, there's a higher probability that you got sick from eating at that particular location than if you went out by yourself and you got sick. We still believe you, but we don't have as much faith. Because you can eat at home, for example, and get infected, but then you don't see symptoms until a couple of days later. So you might blame the wrong place for your symptoms when it's actually not the place that got you infected. Here's another one. People always threaten to sue, and I think they do sue. At least this has happened for some restaurants that had major foodborne outbreaks. And here's the last one. And so the way we work with this data is we have people who read through some of the tweets and do manual labeling to identify tweets that are relevant versus tweets that are not relevant for our classification process. We tend to use very simple machine learning classification, very simple machine learning classification tools, so things like support vector machines, random forest, to do build our classifiers. And then we keep evaluating to make sure that over time, our system does not become irrelevant. For this particular system, we work with St. Louis Department of Public Health and the Chicago Department of Public Health to develop it. So Chicago already had a system that was running on Twitter, and their aim was to identify restaurants that were unsafe. So if you had a lot of people saying that a particular restaurant had made them sick, then they would go out and actually do restaurant inspections to make sure that the restaurant was okay. So we developed a dashboard that looks like this, where the health department can look at tweets from their region where someone says that they've had food poisoning. They can get more details about the tweet. They can respond to the tweet. They can validate the tweet. So this data is only viewed by the health department. So if they click on details, it would take them to something like this, where they see the geolocation of the tweet, and they can get an approximate location of where the tweet is coming from. They can also respond to the tweet, so they have like pre-specified language that they can click on and respond to that individual. So for each report that they get, it generates a unique link that they can click on and then fill out additional information. So this is an example of someone who said they got food poisoning from Chick-fil-A, and then the health department responded to that. So if they click on that link, it would take them to a form like this. They can fill out as much information as they feel comfortable. So this project led to us thinking about other ways in which we can improve food safety. So instead of just looking at people saying they're getting sick, can we actually look at the foods that are making people sick? So we started this other project specifically focused on detecting reports on the safe food products from Amazon review data. So if someone buys a product from Amazon and then writes a review about it, we wanted to see if that information could be useful for detecting unsafe food products. And one of the reasons for this research is that it takes a lot of time for products to be recalled. So this is a case where we had pork infected with salmonella in Washington State in the US. And the first report came in April, but the recall did not happen until August. So by the time we had a recall, so this is called an epidemic curve. So by the time we have a recall, the epidemic is already peaked and is dying off. And so what we wanted to do was to develop a system that the Food and Drug Administration that issues recalls can use to start doing investigations sooner, and then they can do recalls a lot faster and get products that are unsafe out of the market. So here's what the recall process looks like. So you have consumers getting sick and reporting that information, or you have inspections of labs that are then found to be in violation of health codes. And then the agency would do an investigation. So they have to do a very thorough investigation to make sure that if the company sues them, they have something to back themselves up with. And then finally, either the company would issue a recall for the product, which actually makes the company look good, or the FDA, the regulatory agency in this case, would issue the recall for the product. So there are two reasons for recalls. One is that people are getting sick. The other is mislabeling of products. So in this case, we had shared equipment warning that was missing on the product, and people who have allergic reactions to things could actually react to this very negatively. Here's another example. This one is on lemon juice that was not included as an ingredient in the package of the product. So we basically had two data sets, one from Amazon that gives us all this product information, and then one from the FDA. So it should be pretty simple. Just combine the two data sets and create a database, and then look at how we can predict recall, whether a product is going to be recalled or not. But this is data science, and it's never simple. So on the left, you have the UPC code, which is unique for every single product. And then on the right, you have the AC number, which is also supposed to be unique for every single product. So we got data from the FDA, and this is what the data looks like. So if you look at this information, which of those numbers would you say is the UPC code for this product? We have no idea. And this is how data usually looks like in the real world, right? So our first step is to just extract all the numbers that we had and then start trying to figure out how can we identify these unique products. So we know the company that produced the product that's been recalled, and each company has 6 digits that are unique for the products that they produce. So we attach those 6 digits to the numbers that we're getting, and then basically drop all the additional numbers at the end that do not make the complete sequence, and then match these products back to the recall products to see if they actually match and they make sense. And then from that, we created a database where we're linking all the FDA products that we have to all the products that we have from Amazon. This database and data is available in GitHub, and code is available as well for people who are interested in using that. So at the end of the day, we had 1.2 million reviews for all the products that we were interested in. Only about 5,000 of those reviews were for recalled products. Products get recalled, but not very often. So the data is not, there's not a lot of data on that. So that's only 0.4% of our data. So we had a severe imbalance issue, and started thinking about what are ways that we could make our data work for us. We looked at the time series of reviews. So are there differences between recall products and non-recall products in how reviews have increased over time, or just the time series over time? Are there any differences? There weren't really many differences. So the green is for the recall products, and the purple is for the non-recall products, and they were pretty standard. And then we looked at ratings for products, and again, quite similar, so the distribution of ratings. So that was very useful. So what we found was that you will have a product that was recalled or that people are complaining about, but they're still giving it 5 stars. I don't understand why, but that happens quite a lot. In some cases, you see that products get recalled in batches, so you could have 2 different people in the factory producing the product, and one batch would get infected or contaminated, and the other one would be okay. So the product can still get really good ratings because only one batch is infected. So the other thing we looked at was reviews. So we looked at reviews for all the different products in our database. The reviews for recalled products, do we have more reviews or fewer reviews? Could that information be useful? That information also was not very useful. So what we found to be useful was just looking at the reasons for recall that the FDA had posted on their website. So when we gathered all the reasons why products had been recalled and then created synonyms for all those reasons, then we could come up with a data set that would be useful in differentiating between recalled versus non-recalled products. So from that data set, we sampled 6,000 reviews, had manual labeling of those reviews. You had the first 2 categories were cases where people either felt sick or the product had expired. And then in the third case, we had the review does not imply that the product is unsafe. And then lastly, it cannot be categorized. So we dropped the 4th case and just ended up combining the first and the second, and then we had the third as a separate category, so it's basically a logistic regression problem. And so that's what we did. We tried logistic regressions, support vector machines, and lots of other classifiers, and ended up with BERT, Google's BERT, and that was the method that seemed to perform best in our classification problem. So right now we have an F1 score of around 74. We thought it was okay, published the paper, and then got an email from the FDA, and it was like, this is wonderful. So now we're convinced that it's great. So we're going to try to work with the FDA to see if it's a tool that they can actually use in their recall process. And one of the reasons that we found that it was so difficult for us to develop a classifier is that the data that we had for the unsafe food products versus the safe products were actually quite similar. So if you're just looking at reviews and what people were writing, they were actually very similar between the 2 classes. So this is important for several different reasons. Over 600 million people experience illness due to contaminated food globally every year. So early identification of unsafe foods would limit their impacts of individuals' health. It would limit the burden, economic burden of both individuals, but also on the industry as well. And another interesting thing from this analysis is that we had about 20,000 reviews that contain terms related to unsafe foods that maybe should have been products that should be recalled, but were not recalled, and were included in our safe category. So that's all I have. I have some references, and thank you so much for your time.
Hi, thank you for your talk. It's great, fascinating work. In the very beginning of the talk, you mentioned something about concerns of bias in the sampling, or like, you know, some populations might be under or overrepresented when you work with these kind of data sets. I was wondering if you could say a bit more about that. You know, like in particular, like what causes those imbalances potentially, and also any solutions that you've come across.
So for our food safety work, we've looked at data from Yelp, from Twitter, and from a crowdsourced website. And when we looked at data from Yelp, what we found was that most of the data was coming from communities where we had higher income and higher education. And those are not usually the communities that are most affected by unsafe foods. So the problem with underreporting of foodborne illness is not just limited to disease sources. It's something that is true across all the different approaches for surveillance with this particular issue. So individuals from lower income communities are not going to go online. I mean, most individuals don't go online and fill out forms about their experiences. They usually don't call in to public health departments to report that. And there could be so many different reasons for that. It could be that people don't have the time to do that. So if you have 3 jobs and you're trying to survive, you're probably not going to be on Yelp writing about your experience when you should be working. So that could be one of the reasons. There could be also reasons about people not being aware of the systems of reporting and how it could be useful for them.
Okay. Anybody, any other question? Okay.
Hi, Lynn. Thanks for an amazing talk. One question I have, and I think this may also be useful for those sitting with me, is the question of most of this work, to do this really impactful work, you have to collaborate with a lot of people. Do you have either tips or techniques on how you can successfully navigate that path, or can you speak to how people in this room can learn to collaborate with you?
Ooh. I'll answer the second one. If you want to collaborate, just send me an email. The first question, I think persistence helps. So for the Yelp data, when we started working on it, I remember sending the first email and not getting a response. And then like 2 months later, I sent another email, and then I sent another email, and I kept trying to find someone that would respond to my email. And I think at some point they were just like, whatever, let's respond to her. And so then I got a response, and they said, we're interested, tell us about your problem, do a proof of concept, and then we'll give you more data. And that's basically what we did. We did a proof of concept, and then went back to them, and then they gave us a lot more data to work with. So persistence helps. Knowing the people to talk to, the right people to talk to, helps a lot. So sometimes I'll look at studies that some of these companies publish, and then try to contact the individuals that are listed in those studies and see if they would be interested in working with me.
Okay. Any other question? I do have one. So I could throw mine. Mine is about the first project you presented on tracking miscarriages, and you had used topic modeling and sentiment analysis to look at tweets. Mm-hmm. And I was wondering, from the topic modeling in which you discovered, say, that Remimar was the reason why people tweeted about this at this time, was this completely unsupervised on one hand? And then for the sentiment analysis aspect of it, what kind of models do you use to classify them, and like, because I guess models are not perfect, and so how did this impact the analysis of this result and the outcomes, and how did you account for this?
Yeah. So the topic modeling, initial analysis was completely unsupervised, and then after that we did semi-supervised analysis. For the sentiment classification, that was manual, so we had 4 women read through all those tweets and classify the sentiment. And then we basically had a meeting to talk about disagreement. So why did you think this was grief? And I didn't think it was grief. And then try to resolve the disagreement.
Okay, interesting. That's a lot of work then. Great. Seems like you have a lot of manual labelers.
Yeah,
I saw that
it's a lot.
The second project too, there was some heavy-duty labeling there. Okay. So just to follow up with that one, then on that project, is there a way in which this information is being used to then somewhat like help with misinformation or miscarriages somehow somewhere? Because I know you're working with UNICEF and a couple of organizations around the world.
Yeah, so we've presented this work to programs that are designed to educate clinicians about miscarriages, and those people found it very useful, and we need to follow up to see what are ways in which we could produce this, what are ways in which we can produce data that would be most relevant to them. So a lot of this, the initial analysis that we did was just to see if what we observe on Twitter actually matches what we'll get from a survey, which it does. And so the next step is how is information changing across time in the social media platforms, and how can these programs use that information to educate both clinicians and patients as well.
Yeah, very interesting. Machine learning and global health. Happy, thank you, Lane, again once more.